Okay, picture this. You're in the middle of a crazy Saturday shift in a coastal ED, and your next patient is being wheeled in, straight from the beach. Marine envenomations. They can be anything from a simple sting to something terrifyingly fast and fatal. So this is your high-yield guide to cut through all that noise and nail the critical steps every single time.
So a patient hits your resuscitate. Before you even have a clue what actually stung them, your brain needs to immediately jump to the absolute worst-case scenarios. We're not worried about a bit of pain just yet. We're thinking, number one, could this be a catastrophic cardiovascular collapse? Number two, are we looking at rapid respiratory failure? And number three, is this a severe systemic syndrome, like a massive catecholamine storm? Your whole initial assessment is designed to catch one of these three killers right away.
So here's our game plan. We're going to start with what you do in those first 5 minutes. Then we'll get into recognizing the classic patterns, or toxidromes. We'll cover the right tests and treatments, we'll touch on special patient groups, think about the challenges outside a big hospital, and then we'll wrap it all up with a super fast debrief to make sure it all sticks.
All right, Section 1, First Contact. These first few moments are absolutely critical. If you get this part right, you're setting the patient up for the best possible outcome.
It's simple, and it's always the same. Resuscitation comes way before diagnosis. Run through your ABCDEs. Is the airway good? Are they breathing okay? How's their circulation? At the very same time, you've got to get on top of the pain. We're talking excruciating pain here. And while you're doing that, get any visible tentacles or stingers off them and start the correct first aid.
Now this slide is a real game changer because it simplifies everything. Seriously, instead of trying to memorize a dozen different creatures, just group them by the first aid they need. For anything that punctures the skin and has a heat-sensitive venom, like stonefish, stingrays, and bluebottles, the answer is hot water. For the really nasty jellyfish syndromes, box jellyfish and irukandji, you're reaching for vinegar. And for anything that can cause paralysis and spreads through the lymphatic system, like sea snakes or a blue-ringed octopus, it's gotta be pressure immobilization. Simple as that.
Okay, so you've got the initial recess underway. Now it's time to play detective. Marine envenomations love to present in these classic clinical syndromes. We call them toxidromes. Nailing the right one is your key to knowing what's coming next and how to treat it.
And here are the two big ones you absolutely must be able to tell apart. A box jellyfish sting is all about immediate, localized, tear your hair out agony. You'll probably see these classic ladder-like welts on the skin, and the patient can collapse within minutes. Irukandji, it's the complete opposite. The first sting might feel like nothing, but then, maybe half an hour later, this wave of full-body pain hits them, they get the sense of impending doom, and their blood pressure goes through the roof. The key difference? One is immediate and local, the other is delayed and systemic.
Right, let's talk about the silent killers. The bite from a blue-ringed octopus is usually painless, so your patient might not even know they've been bitten. But within minutes, that tetrodotoxin, a super potent sodium channel blocker, starts causing a descending paralysis. It often starts with their eyes, so you'll see drooping eyelids, double vision, then they have trouble swallowing, and before you know it, they're in respiratory arrest. Management is pressure immobilization on scene and getting ready for what could be days of mechanical ventilation.
Now for the things people step on. With stonefish and stingrays, problem number one is pain. I'm talking pain that is completely out of proportion to what you see. The answer is hot water immersion, as hot as they can possibly stand it for up to 90 minutes. With a stonefish, don't forget it can have systemic effects, and there is an antivenom for that really bad pain or if they get sick. For stingrays, you need to think of it more like a dirty, traumatic wound that also happens to have venom. It needs a good clean out, maybe an x-ray to look for a retained barb, and you gotta think about antibiotics.
Okay, Section 3. We've resuscitated them, we have a working diagnosis, so what tests do we actually need to order, and what are our definitive treatment options?
Look, for any really significant envenomation, a baseline set of bloods just makes sense. But for specific syndromes, you need to be more targeted. If irukandji is on your radar, you are actively hunting for heart problems. That means serial ECGs and troponins looking for ischemia or a stress cardiomyopathy. And if you're worried about a sea snake bite, you're on the lookout for muscle breakdown, myotoxicity, so you'll be checking the CK and keeping a close eye on their urine, looking for it to go dark.
The good news is, the list of marine antivenoms you need to know is pretty short, and the reasons to give them are very clear. For box jellyfish, you're giving it if your patient is collapsing or their pain is just not responding to anything else. The dose goes up with how sick they are, all the way up to 6 vials if they're in cardiac arrest. For stonefish, it's for that unbearable pain or any systemic signs. And for sea snakes, pretty much any sign of systemic envenomation gets 1 vial of antivenom.
I want you to really let this one sink in, because it is so important. There is no antivenom for irukandji syndrome. Management is 100% supportive. It's all about controlling that crazy high blood pressure, managing the pain, and dealing with any cardiac complications that pop up. Do not waste a second of your time looking for an antivenom that just doesn't exist.
Section 4, Special Populations. It's something we always have to ask, right? Does our plan change for kids or for pregnant patients?
So, for kids and pregnant patients, the core principles of recess and first aid are exactly the same. The source material doesn't give us specific, separate guidelines. But in practice, that just means you apply the general framework while being extra careful with weight-based dosing and, of course, thinking about the baby. Honestly, these are the cases where you should be getting on the phone to your local toxicology service early.
Okay, let's zoom out from our nice big recess bay for a second. What happens before the patient even gets to you? And what if you're the one dealing with this in a smaller, more remote hospital? Understanding the pre-hospital challenges and the common mistakes is just as important. This right here is your high-yield, don't mess this up list. Pressure bandages are for things that cause paralysis, not local pain, so do not put them on jellyfish or stonefish stings. Vinegar is your friend for box jellyfish, but it can actually make a blue bottle sting hurt more. Never, ever wash the area with fresh water. And if you get a call about a blue-ringed octopus bite, even if the person sounds totally fine, you tell them to get moving. That stability can disappear in a flash. All right, let's bring it all home with a 60-second debrief. These are the 4 things you need to burn into your brain for your next shift.
First, think worst first. That patient comes through the door from the beach, and your mind immediately scans for 3 things: collapse, paralysis, or a hypertensive crisis. Find those first. Second, first aid is not one size fits all. You have to know your big 3 categories: hot water, vinegar, and pressure. Getting it right helps the patient. Getting it wrong can actually make things worse. Third, if you're thinking Irukandji, you are thinking catecholamine storm. Your immediate next thought should be heart. Start looking for evidence with serial ECGs and troponins.
And fourth, a blue-ringed octopus envenomation really means one thing in the end: a ventilator. The definitive treatment is supportive care, and your job is to breathe for them until that paralysis wears off.
And we'll finish with one last question to chew on. So, you've done an amazing job, you've managed the acute phase, you gave the right antivenom, and you're sending the patient home. But your job isn't quite over. What's that classic immune-mediated complication that you need to warn them about? The one that loves to show up a week or 2 down the road. Something to think about. That's it for this explainer.